Hello. Thank you for the opportunity to present our work on behalf of my co-authors. I'm going to be showing our results looking into long-term, meaning 5 and 10 year survival after minimally invasive hepatic resection for hepatocellular carcinoma or colorectal cancer liver metastases. And the message I'm going to try to convey is that based on our data, cure is possible for these patients. Me and my co-authors have no disclosures. A little bit of background. As you are all aware, minimally invasive hepatic resection has emerged over the past couple of decades as a very safe alternative to open hepatectomy with some potential clinical benefits, including low morbidity and hospital stay. In terms of oncologic outcomes, there have been 3 randomized clinical trials comparing open and minimally invasive hepatectomy. The first one, Oslo Comet, looked into 280 patients with colorectal cancer liver metastases and demonstrated that minimally invasive hepatectomy was indeed safe and feasible, but only reported on 90-day outcomes. So there were really no oncologic outcomes reported in this first trial. A second trial named LAP-OP-HUVA looked into 193 patients with colorectal cancer liver metastases, again, that were compared in terms of the surgical approach, open versus minimally invasive hepatectomy. And this trial actually reported outcomes 7 years out from resection. And again, showed equivalent oncologic outcomes, open versus minimally invasive hepatectomy. And lastly, when it comes to hepatocellular carcinoma, there has only been one randomized clinical trial from Egypt, where El Genti and co-authors looked into 50 patients with HCC that were randomized to either open or minimally invasive hepatectomy. And they reported 3-year disease-free survival in their series, being equivalent between the 2 approaches. So as you can see, really long-term, upwards of 5-year oncologic outcomes following minimally invasive hepatectomy are still lacking in the literature. So trying to address this deficit, we decided to look into our own data at the University of Pittsburgh Medical Center. We are a high volume liver cancer center where we routinely perform minimally invasive hepatectomy. So we retrospectively looked into our prospectively maintained database, and we carried the database for patients who underwent minimally invasive liver resection for either hepatocellular carcinoma or colorectal cancer liver metastases between the years 2002 to 2017, so over a 15-year period. Obviously, we extracted basic demographic and clinical pathologic variables, and we used Kaplan-Meier analysis to estimate both recurrence-free and overall survival in each of these 2 groups. So we're able to identify a significant number of patients that met the study criteria, specifically 271 patients, of which 140 had colorectal cancer liver metastases as their region for minimally invasive hepatectomy, and 131 were suffering from hepatocellular carcinoma. So if we look at some base demographics, you will see that median age of the patients was pretty comparable between the 2 groups. They were 63.5 years for the colorectal cancer group and 65 for HCC. The mean number of liver lesions in each cohort was identical, it was 1.4, while the median size of the largest lesion was a little bit larger in the HCC cohort. These were averaging 3.8 centimeters versus the colorectal cancer liver metastases tended to be a little bit smaller at 2.6 centimeters on average. And you will see that the majority of the patients had unilobar disease distribution. Specifically, in the HCC group, 93% of these had disease confined to one lobe of the liver versus 88.3% in the colorectal cancer group. So in terms of the surgical approach, we broke down in three categories. Obviously, every patient underwent minimally invasive hepatic resection, but we tried to be a little bit more granular, and we divided the patients into three groups: the pure laparoscopic group, hand-assisted, and robot-assisted. So if we look at the colorectal cancer group, you will see that 43% of the resections were performed purely laparoscopically, 44% with a hand assist, and 12% using the robot. Versus in the hepatocellular carcinoma group, 2/3 of the patients were operated with a pure laparoscopic approach, about a quarter with a hand assist, and a small number, 5%, using the assistance of the robotic system. Now, in terms of how much liver was resected in the patients, major hepatectomy was more likely to be performed for colorectal cancer liver metastases, as 15% of these patients underwent major hepatectomy, again, minimally invasive way, versus that was performed in only 9% of the HCC patients. And again, knowing that cirrhosis is associated with HCC, it's not surprising that we try to avoid major liver resection if we had to in this group. Furthermore, we looked into whether we had to perform simultaneous ablation in addition to the liver resection. And that was required in about 1/10 of the colorectal cancer liver metastasis group, but was utilized in a quarter of the HCC patients. Our final surgical margins were negative in majority of the patients, 86% of the colorectal cancer group and 80% of the HCC group. You will see that the average length of stay was, I would say, on the low side, 4.5 days for the colorectal cancer patients and only 3.2 days for the HCC patients. Perhaps the higher length of stay in the colorectal group reflecting that they underwent major hepatectomy more frequently. And you will see that we followed up these patients over a long period of time, with the median follow-up being almost 5 years for the colorectal cancer group and 40 months for the HCC group. So let's look into some long-term oncologic outcomes. Let's start with overall survival. You will see our Kaplan-Meier curve that we really have data extending beyond 10 years. Focus first on the colorectal cancer group, and we report that our 5-year overall survival was 60%, 61% to be precise. So more than half the patients alive at 5 years. And that only dropped a little bit up out to the 10-year mark. So 10-year survival being 38%. In the HCC category, a little less than half of the patients were alive at 5 years, 43%, and a quarter of the patients were alive at 10 years, 26%. So there we have more of a survival drop over the initial 5 years, and then also from year 5 to 10, I think likely reflecting the underlying nature of the liver disease. In terms of recurrence-free survival, our data is interesting in the sense that looking at the colorectal cancer group, the recurrence-free survival is pretty much identical at 5 and 10 years, 39% and 37 years, which to us, it means that if you make it to the 5-year mark and you're cancer-free, you have extremely low chance that you're going to recur later. However, this does not appear to be true for HCC, as the 5-year recurrence-free survival was 46%, about half the patients were free of disease, but at the 10-year mark, it was 33%. And again, the underlying nature of the liver disease and the propensity of these patients to develop de novo tumors is likely at fault here. So trying to bring everything together from our data, again, we report that in this very large single institution retrospective series of minimally invasive liver resection for colorectal cancer and hepatocellular carcinoma, in our opinion, we report excellent long-term oncologic outcomes. Specifically, starting with the colorectal group, more than half of the patients were alive at 5 years after resection, and 1/3 survive at 10 years. So for these patients, cure is indeed possible with utilization of minimally invasive hepatectomy as part of their obviously multimodal treatment strategy. The data was not as favorable for HCC patients. Almost half were alive at 5 years, and about a quarter survived out to 10 years. In our opinion, this really underscores the importance that these patients ultimately need liver transplantation for long-term survival. However, for the subset of patients that liver transplant may not be an option, our data shows that minimally invasive hepatectomy can lead to a meaningful 5 and 10-year survival with actually a measurable chance of cure. Well, with all this, I would really like to thank you for your attention. I would really like to thank also my mentors, Dr. David Geller and Dr. Summer Tome, as well as Dr. Steele and Dr. Newing for their help on the project. And of course, our wonderful research coordinators and database managers, Dolly Martin and Madison Meehan. Without the help of wouldn't be feasible to present this data. Again, thank you for your attention. I'll be happy to take your questions electronically, as unfortunately we do not have the chance to meet in person this year, but I look forward to the opportunity in the future. Thank you so much.